Sure. Hi, my name is Mary Beth Weber. I'm an associate professor of global health and faculty in nutrition and health sciences at Emory University. And I have the great pleasure of introducing my friend, colleague, and enrichment co-chair in our Diabetes Translation Research Center, Dr. Guillermo Umpierrez. Guillermo is a professor at Emory School of Medicine and the director of diabetes and endocrinology at Grady Memorial Hospital. He's a well-known expert globally in diabetes management and was just last year the president of medicine and science at the American Diabetes Association. Dr. Umpierrez's work plays a pivotal role in shaping the standards of care for individuals living with diabetes, and he has a career spanning over 3 decades, focusing on multiple components of diabetes management, particularly making significant contributions on beta cell dysfunction and inpatient hyperglycemia. Dr. Umpierrez's dedication extends beyond academia, and he leads the Emory Latino Diabetes Education Program, which provides important diabetes education to the Latinx community. Thank you very much for joining us. And as he shares with us today, the American Diabetes Association, 2023 Standards of Care in Diabetes, a talk I'm very excited about because, like many of you, I know we all sometimes go to these standards to pull the things that we may be working on currently, but having an update over the total clinical recommendations will be a really valuable thing for all of us to hear. Thank you very much. Guillermo?
Thank you, Mary Beth, and thank you for attending. I'm just going to present what I think are the most important facts in diabetes in the update for the American Diabetes Association this year. This sort of potential conflict of interest. Okay, so ADA standard of care had been around for 35 years and is now like 280 pages and different chapters, 17 different chapters. I will just highlight what I think are the most important clinical questions that we have. And also briefly, I'll show you where we just published the recent the American Association of Clinical Endocrinologists. I was the chair for this, and they're very similar recommendations. So we're going to start with screening and why we think that early detection is going to change the way we manage diabetes in the future, in the way that diabetes in the youth is severe, might have more severe consequences than in older adults. We talk about the ADA, AESD guidelines, and how you individualize patient factors for your treatment of patients with diabetes. Standard of care. So why we care? Because in 2022, the CDC published there are 37.3 million people with diabetes, or 11% of the population. The International Diabetes Federation a couple of years ago published that of 550 million people. And the number of people with diabetes, unfortunately, continues to increase all around the world. And it is estimated that about 6.7 million people around the world dies because of diabetes. So there's a significant morbidity and mortalities. And here you have how we have increased the number of the population with diabetes. And here in the bottom, that is a disease that it mainly started at the age of 44, but you have from all over in adult patients. And to the right, why we changed the recommendation for screening is because, unfortunately, less than 20% of people who has pre-diabetes were going to become diabetic, 50% of them in the next 5 to 8 years. They just really don't know they have diabetes or pre-diabetes. So the new recommendation of the ADA is to screen everybody over the age of 35. Even if you're asymptomatic, you have no risk factors at 35. We used to say 45. And if you have risk factors, or you have obesity or overweight, you're going to start screening at age 18. Because we need to recognize these young adults or anybody who has prediabetes, especially in the youth. Here, this slide shows the prevalence of type 1 diabetes, and in the right, prevalence of type 2 diabetes. And these are global US trends, and from different colors, 2001, 2009, and 2017. Let's focus on the left, type 1 diabetes, and you see that in adolescents, the 10 to 14, 15 to 19, the prevalence of type 1 diabetes continues to increase in recent years. And this is dramatic when you see in the right size and the prevalence of type 2 diabetes, especially in minority population, in Hispanics and African Americans, the number of type 2 diabetes, and these are kids, age 10 to 14 or 15 to 19, has increased significantly during the past few years. So not only that we care because of the increased number of people with diabetes, or is that the complications. This is the today's studies, the long-term complications in youth-onset type 2 diabetes. In the studies, they took adolescents, they followed for 5 years old, most of them treated with metformin or insulin, and they continue to follow this patient after the study completed for 10 years. And what I'm showing you is the 10-year follow-up data. And you see that kid with started an adolescent, now must be in the mid-20s, about 50% already have hypertension. Look at the kidney disease after 10 to 15 years, dyslipidemia, nerve disease. And if you compile all the microvascular complications, and these are young adults in the mid-20s, you're going to have 50% of them already have microvascular complications. So they have a retinopathy, nephropathy, or peripheral neuropathy. And of course, the consequence is the increased rate of diabetic foot infection. So this is why the American Diabetes Association now recommends to start early on. And if you have risk factors, you are a minority patient, you're overweight, obese, don't wait until you're 35, screen them as soon as possible, age 18. And if you screen with fasting blood glucose, with hemoglobin A1C, or with oral glucose tolerance test, whatever, all of these tests are good. If you do 2 tests, it's better than 1, but you can start screening with fasting blood glucose or hemoglobin A1C, or the combination of both in high-risk population. And if you pass, you don't have diabetes, you repeat every 3 years. But if you have pre-diabetes, then you have to start screening them on a yearly basis. So when we talk about prevention of type 2 diabetes, the American Diabetes Association continues to recommend lifestyle intervention as the #1 and more effective lifestyle modification that is not only prevent progression, but also may reduce regression from pre-diabetes to normal glycemia, as published by Mary Beth Group. So the recommendation is to lose 7% of body weight and to start doing diet and exercise for at least 150 minutes a week. But this year, we now change the recommended to start lifestyle modifications on everybody. But in those patients that are not effective, because only 35% do well with lifestyle modification, to recommend metformin therapy early on. So who are candidates, according to the ADA, for early on initiation of pre-diabetes management with metformin? Those who are young, because they respond better than the older adults. Those who have a BMI more than 35. A fasting blood glucose, I think this is very interesting, is the fasting blood glucose pre-diabetes between 100 to 125, that's right? That if you are at more than 110, you're at higher risk of developing diabetes. Is the hemoglobin A1C for pre-diabetes goes from 5.7 to 6.4. But if you pass the 6% range, you're going to have a higher risk of those equally to those who has prior gestational diabetes. So lifestyle modification continues to be the mainstay of pre-diabetes management. But in these high group categories that I'm showing you here, you may consider, in addition to the lifestyle modification, early initiation of therapy according to the ADA. So metformin therapy should be considered, right? And long-term use of metformin also is being associated with low vitamin B12 deficiency. This is not very commonly done, but vitamin B12 may be associated with peripheral neuropathy, anemia, megaloblastic anemia. So we should consider measuring once in a while vitamin B12 in those who are being in long-term therapy. Unfortunately, this is very seldom done. The other thing that ADA, the last year or 2 years, have becoming very strong in the recommendations of weight obesity is a disease. It's not how you look, but it's a disease that is associated with increased morbidity and mortality. And the ADA is working with the Obesity Society, is trying to get guidelines how to manage patients. And of course, this is important because in this country, by the year 2030, we expect that 50% of the American population will be obese. And 1 out of 4 will have morbid obesity. And the World Obesity Atlas in 2022 predicted there will be 1 billion people globally living with diabetes. So obesity is perhaps the real epidemic of this center, with equally or more important than diabetes itself. So the American Diabetes Association for Weight Management says small and larger goals need to be differentiated case by case. So a small weight loss, just 3%, reduces the risk of progressing to diabetes and improve in those who have diabetes metabolic control. So if you can lose 3 to 7%, ideal. We also now we have learned that larger sustained weight losses, more than 10%, so more than 15, 20 kilos, is usually associated not only with improvement of diabetes control, that in those patients who have short duration of diabetes, less than 5 to 10 years, we will see remission of diabetes. What do we mean with remission of diabetes? It means that those individuals who, after losing 10% of body weight or more, they are able to control the diabetes, achieve normal glycemia or hemoglobin A1c less than 6.5 off medicine for at least 6 months. So the group of the UK has been very active, and this is one of the results of the studies they published in the Lancet Diabetes Endocrinology, and they have a couple of publications. But I just want to focus your attention, what happens if you lose just 5%, 5 kilos or 10 kilos? So 10 to 20 pounds, about 25 to 30% are off medicine. If you're able to lose 10 to 15 kilos, so it's hard to do it, but if you're able to do it, about 50 to 60% achieve diabetes remission. So you're off medicine with good diabetes control. And if you are a successful individual who loses more than 15 kilos, 70 to 80% of them have diabetes remission. So we understand that it's very hard to lose weight. But now we have not only diet and exercise, but we have medications that can help you to achieve these goals. And we have data with semaglutide, 2.4 milligrams medication that is given once a week. And in these individuals, you see that people can lose about 10% or 15 kilograms and improvement of glycemic control with a reduction of hemoglobin A1c about 2 to 2.5%. And we also now have the new GLP-1 GIP, a combination that is called tirzepatide, that you can achieve body weight of about 10 to 15%. We have participated in the tirzepatide trials, and I have seen patients losing 50, 60 pounds in the 6 to 12 months of follow-up. So now, if we know that you have a risk, now we are considering the intervention with weight management for many patients. We still need to learn more about what do you do long-term when you achieve the weight loss. Let's say I lose 20 or 30 pounds. How do I maintain my treatment? But we know so far, if you start treating patients with obesity, this is a lifelong treatment. Same as diabetes. That's right, you start on medication, it's forever. Same as hypertension, same as dyslipidemia. Obesity is a disease that needs intervention, and we need to find out with lifestyle modifications or medications. And the list in the pipeline of new agents is amazing, what we see and we're going to have in the future. The other thing that the ADA still publishes is the need for surgery. And these are recommendations for the treatment of obesity. They're not new, they have been going around for a while, but everybody, do start with a BMI of 25, you do lifestyle modification, up to 30, pharmacotherapy when you have high-risk populations, and metabolic surgery for those who have more than 30 of BMI, diabetes, and other risk factors. So are we going now to decrease the number of bariatric surgery now that we have all this medicine? Yes, unfortunately, they are very expensive, and the access to medication for weight loss still very deficient around the world. The other aspect is diabetes technologies, right? This has been amazing what we have, and Emory now has a program to implement CGM in all primary care sites. And we just had a meeting this weekend. Thank you for attending. Those who attended, it went extremely well. You will have the ability to wear and learn the CGM directly in the next year or two. And we're going to go to Grady, starting, I believe, in September, October. And we're going to have both Grady and Emory sites trying to implement CGM in primary care. So what the ADA would recommend is that everybody with type 1 diabetes should have access to a CGM or a continuous insulin pump. Those who are taking insulin with type 1 or type 2, they are candidates to wear the CGM, because we know that hypoglycemia that is associated with increased cardiovascular events, about half of those events are asymptomatic. So in particular, who has asymptomatic hypoglycemia? First, those who have repeated episodes of hypoglycemia, the body loses the ability to recognize hypoglycemia. This is a condition that is called hypoglycemia unawareness. So if you have an individual who is having repeated episode of hypoglycemia, likely he or she would not be able to recognize hypoglycemia. Now, the continuous glucose monitor have alarm, who will tell the patients or the caregiver or the spouse or the friend that the patient is having hypoglycemia, and you can be rescued. And the treatment to overcome this hypoglycemia unawareness is not having hypoglycemia for at least 1 or 2 months. After 2 months of not having hypo, your body recognizes again hypoglycemia. The other thing is patient who has multiple comorbidities, especially chronic kidney disease, end-stage kidney disease, where the hypoglycemia is very common. Older adults over the age of 60 to 65, the ability to recognize hypos is much, much less. So in those patients with high risk, CGM is recommended for those who are treated with insulin. And we have 2 types of CGM. That's right. One to give you real time or give you the continuously glucose values every 5 minutes, or it can be intermittently scanned like the Libre 2 that you have to flash at least every 8 hours. So both are in the market. Both are going to be to your utilization and learning about at Emory University. And when we do the glucose assessment, we now have what we call the ambulatory glucose profile. The ADA and organizations around the world have recommended a target range for a patient with diabetes between 70 to 180. And this is what we call time in range. So this here is the green. We want this to be at least 70% of the time. You should be between 70 to 180. And we should avoid high blood glucose, what we call time above range, more than 180, more than 250. And equally important, as I mentioned before, we really want to decrease time below range in these patients. So time below range is less than 70, and clinical significant hypoglycemia is less than 54. So we want to minimize the lows. And of course, here you have most of the hypoglycemia, especially asymptomatic, occurs in the middle of the night. If I bring your blood sugar down during the day or during the night, your ability to recognize hypoglycemia is much less at night because the secretion of catecholamine, epinephrine, is less at night than during the daytime, especially in older adults. So big change. We're not recommended the Abbott, the Dexcom, the Medtronic, whatever you have to your access. That's what you have to do to treat patients with diabetes. And every insulin treated, especially those at high risk that we just talked before, are candidates for CGM use. The major changes in diabetes control has come during the last decade, not only because we have new agents, but we have a large number of clinical trials. First, what are the glycemic targets? The ADA, the European Association for Studies Diabetes, recommend a target less than 7%. ACE, the American Association of Clinical Endocrinology, less than 6.5. So where did this 7% came from? It came from two large studies. One, the Diabetes Complication Control Trial, DCCT, in type 1 diabetes in the late 80s to 90s. That they target hemoglobin A1C less than 7. And the United Kingdom Prospective Diabetes from the UK, of course, that also target less than 7. So they demonstrated that complications is markedly decreased with less than 7. The ACE says, well, why do you stop at 7? You can achieve 6.5 if there is no hypoglycemia. In reality, both the ADA and ACE say the same thing. The ADA this year we published that if you can achieve less than 7, if you have a young person, you should try to achieve normal glycemia as much as possible, especially with new technology. So how I think that the following information is kind of interesting because we don't go just 7. It has been a transformation during the past 30 years. From 1990 to 2008, we only care about efficacy. Bring that hemoglobin A1C down. I'm just going to present the data from the UK PDS, the English studies, the British studies. Then you have the 3,500 patients with newly diagnosed diabetes with lifestyle modification. They improve. And they wanted to have at least 1% difference throughout the trial. The trial lasted for 6 years. Then you see that there was significant difference in the intensive control versus the conservative or conventional approach. So one, we wanted to have less than 7%. So just keep in mind that this trial was published in 94, 96. So we didn't have all this new insulin. We have just human insulin. We have sulfonylureas and we have metformin. There was none of the other new agents. But despite with the old trials, having glucose control, showing to the right is the risk reduction in complications, especially microvascular complications. They will reduce by about 25 to 30%. So glucose control has been shown to be extremely important in preventing microvascular complications. They also, not significant, but reduce 16% myocardial infarction. And I do remember when this paper came up, and it says that for each 1% reduction of hemoglobin A1C, so going from 10 to 9, 9 to 8, 11 to 10, you reduce the risk of death by 21%. It reduces microvascular complications, the eye, the kidney, the nerve, by 37%, and myocardial infarction for 14%. That's why during the years up to 2008, efficacy was the most important. So in the next few years, knowing that cardiovascular complications, acute heart attacks, strokes was the #1 cause of death. If you have a patient with type 2 diabetes, 60% of them are going to die of cardiovascular events, or stroke, peripheral vascular disease, myocardial infarction, and heart failure. So there were several trials trying to improve glycemic control in order to reduce cardiovascular events. And we had the ACCORD trial, over 10,000 patients in the United States. Emory at the VA with Larry Phillip has 180 patients in these studies. We had the ADVANCE trial, mostly done in Australia, New Zealand, Canada, and one site in the United States. They use mostly sulfonylureas. And we have the VA diabetes trial in 35, a little over 3,000 patients at the VA hospital. And all of these trials trying to minimize glucose control, improve glucose control to a hemoglobin A1C less than 7, and the ACCORD less than 6.5%. Unfortunately, no difference of glucose control reducing cardiovascular events. And what we observe is that if you try to go to 6.5, you're going to use multiple medicine, especially insulin and sulfonylurea, and there is an increased risk of hypoglycemia. The ACCORD trial was stopped because an increased mortality rate. Then there was an increased cardiovascular events in most of these trials. So in a meta-analysis, you're going to have a significant increased risk of complications. So currently, what we said is trying to look for 7 for most people, if you can achieve that in a safe way. And in 2015, the American Diabetes Association recommended to be 7 as a goal. But then you have to decide according to who is in front of you, who is your individual, who is your patient, and you're going to be more or less stringent according to complications. So if you have hypoglycemia risk, so kidney failure, lack of education, insulin therapy, remember there are only 2 medications associated with hypoglycemia: insulin and sulfonylureas. So if I'm treating somebody with sulfonylureas, I'm not going to go to less than 7. I want to keep it in the middle to prevent hypos. If I have a patient already with complications, let's say have cardiovascular disease, kidney disease, or end stage or dialysis, the train already left this patient. So I don't have to be that stringent. But more importantly to me is the fact that nobody can tell me what is the ideal hemoglobin A1C, and not for everybody is less than 7. You have to individualize care. So you and your patients, according to research, the support system, you're going to have the individualization of goal of the algorithm for treatment. So in the last few years, we went from efficacy to safety. And now for the last 5 years or 4 years, now we recommend drug selection according to, because there are now several trials that have shown to have drugs that have shown to have cardiovascular and renal protection, like the GLP-1 and SGLT2s. So in this year, 2023 guidelines, we don't recommend that everybody should be treated with metformin. So metformin is fascinating. It's a great drug, very potent, equally than any other drug. But once you have complications, maybe it doesn't prevent some of the complications or progression of complications. So in those individuals who already have cardiovascular disease or renal disease, the use of SGLT2s or GLP-1 is recommended. But I don't know how many 100% clinicians are listening to this lecture, but I think that the treatment of diabetes should focus on reduction of glucose or improvement of glycemic control. And you can use all of the drugs available. They all bring the blood glucose down. And if your goal is to bring the glucose control, improve glucose control, you can choose among any one of them. But if you have already complications or individuals at high risk of complications, so older age, multiple risk factor, hypertension, dyslipidemia, obesity, you're going to use GLP-1 and SGLT2. But that doesn't mean that the all drugs don't work. They still work. And if you remember the UK PDS, they still have a very important role in prevention of microvascular complications. So for me and all the clinicians, we know that we have 13 different groups of medicine with different mechanisms of action for the treatment of diabetes. So the clinician would say, well, which one should I use? So let me give you a couple of minor things, suggestions on the current drugs of medicine. So metformin, it's my first love. That's right, on diabetes care. Has been around for 50 years or more in Europe, 40 plus years in the United States. It works extremely well. Bring the hemoglobin A1C 1 or 2%, equally or more than most of the medicine that we have right now. It works fairly fast, low cost, no weight gain, and may have some potential microvascular improvement. You have to start in a very low dose. If you start metformin, it's for the next 5, 10, 20 years. So don't rush. Start with 500 milligrams once a day, increase to 1,000 milligrams, increase to 2,000 milligrams as tolerated. If you start on higher doses, the patient is going to have nausea, vomiting, or diarrhea, and ooh, doctor, don't give me that thing. So please start slow and avoid using in patients who has significant chronic kidney disease with a GFR less than 30 because of the risk of lactic acidosis. And we recommend that half dose for the GFRs between 30 to 45. Works well, bring the glucose down. But if you have already somebody with cardiovascular disease, with heart failure, with renal chronic kidney disease, the use of metformin doesn't protect the progression of chronic kidney disease or cardiovascular complications. Bring the glucose down, but it doesn't change the long-term outcome. What about sulfonylureas? Well, 30% of Americans are on the sulfonylureas, 28 to 30%. 50 to 70% of people around the world on sulfonylureas. Why? Because it worked fast, 1 or 2% reduction of hemoglobin A1C, low cost, is once a day, most of them. But it has issues, that's right, disadvantage, hypoglycemia, that is seen in somewhere around 5 to 30% in different trials. And you have to be careful in those who have chronic kidney disease or liver disease. And if you have a patient that already have cardiovascular disease or renal disease, it doesn't help you in slowing down the progression of CKD. And if you have somebody with ischemic heart disease, if they have hypoglycemia, you have the risk of increased cardiovascular events. So they're still there. I think that they're going to continue because it's so cheap and easy to use. But you have to be careful in those patients who already are cardiovascular disease or kidney disease. What about thiazolidinediones? Now, there used to be 3 in the market. Now we only have 1, pioglitazone. No, it works well. It's as good as metformin in reducing hemoglobin A1C. No hypoglycemia. It's once a day. It's cheap. It's generic. But it's associated with weight gain, and most people gain between 2 to 4 kilos. So if you tell me, I'm going to give you this medicine and you will have the chance to gain 4 kilos, I say, oh, doc, don't give it to me. The other thing is low onset of action. You have to wait up to 2 or 3 months to see the maximal effects. And we know that it's associated with increased risk of heart failure. And more important to me is in postmenopausal female, the risk of osteopenia and bone fractures that have been shown in different studies. Not for men, not for premenopausal female, but in postmenopausal, especially in the high doses associated with bone loss. So do we use thiazolidinedione? 1 out of 3 patients with diabetes type 2, 25 years ago was on a thiazolidinedione. Now it's less than 4%, mainly because of the disadvantages that are shown in the right side of this slide. And if you have already somebody with cardiac and renal protection, There's no good data on established in randomized clinical trials. So I use it, yes, for those who don't have insurance. What about DPP-4 inhibitor? There are so many. There are 4 in the United States. There are 7 in Japan. Who knows how many in other countries? So the good thing that have no major adverse events, side effects. You don't know that taking a medicine, no hypoglycemia, can be used in patients who have chronic kidney disease, even in dialysis. So I like this agent in patients who have older adults, those who don't want complications. But the problem is that the efficacy, so the ability to reduce hemoglobin A1c is just 0.4, 0.8%. So if you have somebody with 8.5, 9%, this agent is not going to get you to goal. But if you combine DPP-4 with metformin, you get a 2% reduction of hemoglobin A1c with no additional adverse event together with metformin. Be careful, some of them need dose adjustment. But the utilization that used to be about 15 to 20% 10 years ago, right now is less than 10% in the United States. Why? Because of the high cost, and more importantly, because several randomized control trials have shown that there is no reduction in cardiovascular events and no chronic kidney disease protection. So there you go, selective use of this agent for the elderly. We know that if we use all of these agents, they're going to fail. And there was a recent study funded by the NIH, 5 years prospective studies and the large studies, that they got 6,000 patients with hemoglobin A1c between 6.8 to 8.5. They were all treated with metformin. So the question was, if I add a second agent, which is best? So they use sulfonylurea, so glimepiride, sitagliptin, a DPP-4, GLP-1, liraglutide, or insulin, glargine. So which is better? Well, let's see glucose control. And to the left is hemoglobin A1c more than 7. So who failed more than 7? And you see there's all of them failed. And here's hemoglobin A1c, they all work. So here you have liraglutide in blue or glimepiride. And glimepiride works extremely fast, but it's the #1 who fails long-term. But there is no major difference. So minor difference in glucose control in favor of insulin and on GLP-1. But all of these agents work. But all of these agents, most of these agents tend to fail with time. We want to prevent complications. So the question was, what about microvascular complications? And here you have, there was no difference in microvascular complications. So no difference in nephropathy or albuminuria or the need for renal impairment or renal dialysis or peripheral neuropathy or diabetic foot ulcers. So these data confirm the previous data on UKPDS. Bringing hemoglobin A1c down prevent microvascular complications in these agents. No different how you do it. So the other is, what about cardiovascular outcomes? And here you have, we see differences. With the blue line is the GLP-1, has better any cardiovascular disease or major adverse cardiovascular events, so acute myocardial infarction, stroke, or cardiovascular death, was reduced with GLP-1, and there was no difference if you use insulin, sulfonylureas, or sitagliptin. And death for cardiovascular, no difference for the other 3, but GLP-1 is there. So this GLP-1 had been shown in this trial. Unfortunately, they didn't study SGLT2s. But we have a paper, hopefully to be approved in JAMA, that we have data with a group of the Mayo Clinic on 1 million people, individuals with type 2 diabetes with combination therapy, that GLP-1 and SGLT2s have the same effects on cardiovascular complications and renal complications. So So it looks like, although this was not studied on the grade, there's
Here,
data in favor of using GLP-1 and SGLT2s.
can you tell?
Yeah. Oh, so complication-centric. I already mentioned cardiovascular disease or chronic kidney disease, and this data is very solid. Multiple studies. This is just an abbreviated collection of trials. The leader trials, semaglutide or albiglutide, they all show that using GLP-1 in high-risk population is associated with a reduction of about 15 to 20% of MACE, major adverse cardiovascular disease, cardiovascular death, non-fatal MI, and stroke. And you see that there is a group effect. All of them were positive. And in addition, there is some data that suggests that GLP-1 reduces the risk of albuminuria and the need for dialysis in long-term individuals. So no question that GLP-1 has cardiovascular and renal protection. Similar data have been shown with SGLT2 inhibitors. Here's data with EMPA-CANA and dapagliflozin on the impact of cardiovascular events or MACE. And you see similar that we observe, most of them similar to the GLP-1. But the big change has been on heart failure. Heart failure is one of the most important complications of diabetes, with 50% mortality, 50% mortality in 5 years. And if you use SGLT2s, the rate of readmissions and the rate of heart failure is reduced by 30 to 40%. And this is a class effect throughout. And now we have data in low ejection fraction, preserved ejection fraction, it works. And now we also have data that SGLT2s are effective in both in people with and without diabetes. And our cardiology friends have now accepted SGLT2 for the treatment of those patients with or without diabetes, because the effects on diabetes is minor, not great effects on SGLT2s. It doesn't produce hypoglycemia. You can use it at any blood glucose concentration. So the recommendation this year of the American Diabetes Association is those patients who have heart failure, chronic kidney disease, established cardiovascular disease to use an SGLT2s or a GLP-1. How do you define chronic kidney disease? A GFR less than 60 or the presence of albuminuria. And in people, you should use it independent if you use metformin or not. Here is a meta-analysis. In the top, SGLT2s, in the bottom is GLP-1. If you use metformin, good effect. If don't use metformin, no difference. So the same thing for GLP-1 and SGLT2s. And it doesn't matter if you have good hemoglobin A1C less or more than 8.5, the effect is there. So the recommendation is those patients who have chronic kidney disease, GFR or albuminuria, CKD or heart failure, to consider the use of SGLT2s or GLP-1. Because all of the other medicines do not have these beneficial effects on established disease. So these are the new recommendations. Patients who have atherosclerotic cardiovascular disease or high risk. So who is high risk? More than age 55, obese, hypertension, dyslipidemia, family history. So you're going to use a GLP-1 or an SGLT2. If you have a history of heart failure, SGLT2 should be given because GLP-1 has minor effects on heart failure readmission. If I have a patient with heart failure, not using SGLT2s would be poor practice. For those who have chronic kidney disease, so GFR less than 60, albuminuria, several studies with all of these agents have shown a beneficial effects of SGLT2s in reducing progression of the disease, slow down of the GFR or chronic kidney disease. Now we can use most of them up to the GFR less than 20. And everybody who has and albuminuria more than 30, for sure more than 200, should be in one of these agents to prevent cardiovascular mortality. And similar what I mentioned, that the SGLT2 is good for people with and without heart failure, with or without diabetes, the same thing for chronic kidney disease. And the studies in the New England in the last 2 years with dapagliflozin, it's called DAPA-CKD, 1/3 of the patients have no diabetes. And the EMPA kidney disease just published last year, or early this year, with 50% of the 6,000 patients having already albuminuria, having already decreased GFR, the use of SGLT2 was effective, no difference if you have diabetes or non-diabetes. So these agents have really changed the way we think. And just for completion, we still have like a few more minutes. Let me just talk to you about two basic questions about blood pressure and lipid management. So the ADA was lag behind the American Heart Association, the internal medicine recommendation that blood pressure should be 130/80 or less. And we used to say 140/90, and if you have risk factor of 130/80, now we changed and we joined the rest of the world. Now we said less than 130/80 should be the goal. But I want to call to your attention one important factor. You need 2 blood pressure higher than 130/80 to diagnose hypertension, because you're going to diagnose for the rest of the world. And the other recommendation is how you check the blood pressure. So the blood pressure, the patient comes to your office and they have to be sitting for at least 5 minutes, resting to check the blood pressure. I mean, if you are fighting for traffic, parking lot, you're always late to your appointment, you rush to your clinic, your blood pressure is going to be high. So you have to get the patient resting for at least 5 minutes to trust that blood pressure. Or check it at the beginning and repeat it later on to make sure the blood pressure is 130/80. If not, you need 2 measurements before you diagnose hypertension. If the blood pressure is quite high, you don't need to repeat it. And the goal is less than 130/80 if it can be safely attained. So which medicine? There are so many blood pressure medicines. So the American Diabetes Association will recommend in somebody who has hypertension to look at the urine analysis, at the urine. And if the patient have albuminuria, so albumin creatinine ratio more than 30, you should use ACE inhibitor or ARB, angiotensin receptor blocker. If there's no albuminuria, you can start wherever you want. There are so many, and there you go by race, access, and you can use a calcium channel blocker, diuretic, or ACE. And if the blood pressure is greater than 160 over 100, use 2 agents, not just 1, 2 agents from the beginning, and independent if they have albuminuria, 2 agents. So what about statins? For the past 5 years, the American Heart, the American College of Cardiology, and ADA have recommended that everybody with diabetes with age 40 to 75 should be on statin. We still say that, but now we want to reduce LDL at least 50%, and the target LDL cholesterol less than 70. And one message this year is there is no low LDL. The lower the LDL is good. So if you start statin and the LDL goes to 45, great. You don't need to get decrease the dose. We want everybody to have less than 70. And if you don't achieve that, and the patient has multiple risk factors or already have an event, do not satisfy with 75 or 80. We want to be less than 70, and it's possible less than 50. And you should use ezetimibe or PCSK9 inhibitor. For many years, PCSK9 was for the lipidologist, lipid expert. Now endocrines and primary care have access to this drug because there's no question that you can decrease cardiovascular events. The other question was, what about age? More than 75, are you protected or you still have to use statins? And the answer is yes. So if somebody has been over the age of 75 and have been taking statins, please don't stop it, continue. And if you have multiple risk factors, you should consider using statin even if the patient is more than 75. In the older adult, please start with a lower dose statin because of potential side effects such as muscle weakness, muscle aches, and pains. So start with ROSI 5 milligrams, and you can increase as needed according to tolerance and according to the effects of the LDL. And very, very briefly, our ACE guidelines, of course, I'm an endocrine guy, so I was very involved with these guidelines, and just 3 slides to highlight 2 differences. The pre-diabetes algorithm, and I know that some of you are experts in pre-diabetes management, they still do lifestyle intervention. But what is interesting is the importance in the text that we put on cardiovascular risk reduction. Having pre-diabetes doesn't only means that the patient have a risk of diabetes, as a 2 to 3-fold increased risk of cardiovascular events. So those patients with pre-diabetes look at risk factors, check the blood pressure, control the blood pressure, control the lipids, and of course, control the excess of body weight. So the treatment of pre-diabetes to progression is lifestyle modification. But in those patients who need to lose weight, now we have several agents like we discussed before that help you to lose 7 to 10% body weight. But you still can use metformin, pioglitazone, acarbose, and other medicines. And this is such an important thing, is on the cardiovascular risk prevention. And they agree with the ADA. If you're just getting the blood sugar down, you can use all of these agents. They are preferred. For example, if you have somebody who is overweight and obese, use a GLP-1 or GIP GLP-1 because you can achieve 5, 10, 15% body weight. SGLT2, not great weight loss, but 2 or 3 kilos most people lose. If somebody has hypoglycemia risk, avoid sulfonylureas. Be careful with insulin, but try to use agents that are not associated with hypoglycemia. If cost is an issue, you have generic agents. And for those patients with severe hyperglycemia, if the patient comes with polyuria, polydipsia, weight loss, they are in catabolic state, the treatment is insulin, together with GLP-1, together with metformin. If the patient already have complications, as I mentioned before, if you have atherosclerotic cardiovascular disease, use GLP-1 and SGLT2. Heart failure, SGLT2. Stroke, this is a lot of controversies in diabetes, but pioglitazone has been shown to reduce the risk of stroke in patients with pre-diabetes. And if you have CKD, SGLT2s, and GLP-1 is also a recommendation. So we have changed so much during the past 5 to 10 years. Now it has good data that if you want to bring the blood glucose down, use all the traditional agents or the new agents. That if you have already chronic kidney disease, cardiovascular disease, or heart failure, the data clearly support the use of SGLT2s and GLP-1. And of course, we have now insulin delivery. I didn't touch insulin, but we're going to have insulin that is going to be given once a week in the near future. Both the 2 companies are working on this, and it looks like the administration of once a week insulin is as good as everyday insulin. Of course, I just need more time. I didn't cover insulin today. So I'm going to stop there and open for any comments or questions from you. And thank you so much, Jeff and Mark, for the opportunity to talk to you today.
Thank you so much for that fantastic talk and review. I have a question regarding then, I guess maybe it's just a reiteration of which of the drugs would be appropriate in prediabetes, because it sounds like it would be necessary to have a very comprehensive understanding of a patient's comorbidity stance. And so you might in prediabetes prescribe an SGLT2 or GLP-1. Is that correct?
Yeah. So what is the issue with the use of GLP-1 and SGLT2 in this country? Unfortunately, less than 20% of primary care prescribe them. If you just look at GLP-1, the once-a-week injection or daily injection, utilization is less than 15% in primary care. Why? Cost, access. Some of them need pre-approval, so doctors don't like to spend time getting pre-approval. And the fact that it's an injection. SGLT2s are easier to use. But if you look for, if let's say I have a 35-year-old patient with pre-diabetes, I'm not going to use this agent because it costs $200 or $300 a month, and I can achieve the same thing with metformin for pre-diabetes. Now, 95% of those patients who has pre-diabetes with the use of semaglutide or the use of tirzepatide go from pre-diabetes to normal glycemia. So you achieve normalization of blood glucose with this agent, but the cost of GLP-1 is somewhere around $800 to $1,000 a month. So not everybody have access to these medicines, unfortunately, but the effects is great. And if we believe that obesity is the #1 risk factor for the development of pre-diabetes and diabetes, the agents that are really associated with weight loss are GLP-1 or GIP-GLP-1 combination. So I think that if I have a crystal ball, where are we going to be talking 5 years from now, is targeting obesity as the #1 risk factor and the associated with comorbidity and mortality of those patients with. And are we going to still doing bariatric surgery? I'm not sure. I mean, I will try medicine. But I'm learning to use this medicine for treatment of obesity a lot. Now, you have to tell the patient that if you start GLP-1, let's say you start semaglutide for weight loss, okay? And you have to tell them that this is for, if they stop the GLP-1, if they stop the tirzepatide, in 2 years, you are back to level 0, where you were in weight, where you regain body weight. If you stop the medicine, I have seen patients in our trial that lost 50 pounds and they regained 20, 30 pounds in 3 months. And you ask them, you change your eating? Nope. So I have no idea, but they need to know they're willing to take an injection once a week for the rest of their life or until something else comes across. And that is a big issue. I mean, but definitely patients like it, if you don't have somebody who work on your pre-approval, it is a pain because some of them require pre-approval before you use them.
Thank you. That's so illuminating. I appreciate that.
All right.
Hi, Guillermo. This is Satish from Emory University.
Yeah.
I have a quick question. My question is regarding heterogeneity of pre-diabetes and how different types of pre-diabetes respond to different lifestyle interventions. So I see in all guidelines, including ADA, that one size fits all is what is currently recommended, like losing weight, 7 to 10% of weight with low calorie diet and 150 minutes or more physical activity. Is there any, because we right now, there's more evidence showing that not all pre-diabetes phenotypes respond to same lifestyle intervention. Say, for example, we are going to publish this data soon, showing that routinely recommended lifestyle interventions like ADA, what ADA recommends, work pretty well in people with IGT, but not in people with IFG, because the pathophysiology between these two pre-diabetes phenotypes are different. So is there any move, or is ADA thinking about incorporating different lifestyle interventions or different prevention strategies based on different pre-diabetes phenotypes?
So
Thanks.
Hey, Satish, great. So I'm scared to answer this question knowing that Mary Beth is looking at me, and I just read and copied some of her slides and a meta-analysis in a presentation that I'm giving next week at the ADA. And I think lifestyle modification works, that's right. And traditional, based on the diabetes prevention program, the target was 7% of body weight. And the same thing with the Finnish studies, that's right. Unfortunately, not everybody had reached the 7% body weight. How do you do it? It says diet and exercise is the combination that you're going to do. Now, the ADA is in a couple of areas is working on exercise, that's right. And it should be aerobic and anaerobic resistant exercise, especially because of the sarcopenia that we see in the obese and the older adults. So if you ask me, I mean, we always recommend to have exercise, both weight and aerobic exercise. And everybody should be referred to a nutritionist. And we do that. And of course, you guys at Emory have done this national prevention program for so many years. So I guess you are the experts in that field. I don't know if Mary Beth or anybody else has an additional answer for Satish's questions or comments.
No, I sort of had the same question he did, in a way that I think that, it's always a challenge with these wide recommendations that are supposed to apply to the general population. When, what Satish is referring to as work in like DCLIP and the Japanese study, and a couple of other studies that pretty convincingly show that for isolated IFG, this sort of DPP style traditional intervention isn't effective in reducing diabetes risk. And I suspect that the body of evidence is not there yet, Satish, for groups like the ADA to feel comfortable. And plus, there's probably some political issues around the DPP being a national US program, and some support behind that wanting to be sort of the cure-all, when the evidence is starting to show that it's probably not for everyone with every type of prediabetes.
Yeah. And I mean, I think the CDC and every organization that work on diabetes prevention program are right in recommending lifestyle modification. But we know that significant number of people don't achieve the weight loss with the exercise that is recommended. So you can imagine the amount of discussion to move and recommend pharmacological intervention early on when you don't achieve these goals and you're still having high risk. A glucose from between 110 to 125, very high risk. A hemoglobin A1C more than 6.1%. How long would you wait until, if you not normalize your hemoglobin A1C less than 5.7, your glucose less than 100? When do you start intervention? And I think that the goal this way is pushing to combine this lifestyle modification with early on metformin, because we know in the DPP, those who were on metformin, who normalized the oral glucose tolerance test, the chances to develop diabetes was significantly less. And the same thing with lifestyle modification, that's right. So your goal is not just to prevent diabetes, but maybe even achieve regression in this population. Anyway, all right. So thank you so much. It's so good to do this for you and review this topic for myself. So take care.
Thank you, Guillermo. Have a great day.